Axillary block is very easy to do. Let me show you a quick axillary block. This patient is going to have an operation on the wrist, especially on the radial aspect. Patient's consented, mark, cleaning, lots of gel. All the nerves are generally around the artery. There are three major codes there: median, lateral, posterior. The median becomes the median nerve, the lateral becomes the ulnar nerve, and the posterior becomes the radial nerve.
Patient's arm to 90 degrees and place the probe in the transverse orientation over the axillary artery. The radial nerve has a reputation as difficult to visualize, but it always lies on the conjoint tendon, next to the artery. It is larger than the other nerves and always has a vague outline until local anesthetic is injected around it. The median nerve is always adjacent to the coracobrachialis muscle. The ulnar nerve is always superficial to the radial nerve and posterior to the artery. Tilt the probe as needed to optimize visibility of the arterial wall fascial planes and the nerves.
Okay. And also you've got the musculocutaneous nearby. This is the muscle. Sometimes you can hit the lateral cutaneous, which you miss in the axillary block.
It comes from C8 to T1.
Thus, in the center is the musculocutaneous. It's in the muscle. It's like a pyramid, triangular shape. And here's the artery.
All the nerves go along the artery, so it's very easy to spot it.
That's artery pulsating. Under there, you could see the posterior cord. So here is the median cord, this area. This is the posterior cord, and here is the lateral cord. Center. This is the musculocutaneous nerve. This nerve, you could see it now. You see this nerve?
You should give reasonable pressure with the ultrasound probe to see and visualize the nerves. They say if it's an awake patient, it might hurt a bit.
You need to go here, hydrodissect it, and keep going to the other side and inject it.
Okay.
And here we'll come underneath, inject it, go here, push it up, and inject it here.
Yeah.
That's it. Yeah. Okay. That's fantastic. Look at that needle going to the musculocutaneous. Let's aspirate and inject 2-3 mils there. If you could push your needle head slightly underneath, maybe. Yeah. Good. Bit closer, bit closer. Yeah, that's good. A bit more. Keep pushing. Yeah, that's okay. Yeah, that's enough. You could catch the artery now, and we will go underneath
the
and
musculus.
inject to the posterior. Push. Yeah. So while you're going, wriggle the needle. So roughly, if you don't see, you will feel it.
Yeah.
That is. Give a little bit more pressure on your probe. Okay, that's good. That's good. That's good. So if I can see the tip, yeah, aspirate, yeah. That black bit is quite safe to inject. If anything white, I would big question there to inject, because the nerves looks a bit whiter here, and I could see on the tip of your needle, I could see the round thing get pushed out. Okay, that's the nerve. Now you could see it clearly, yeah?
Yeah.
The nerve's getting pushed out. Okay. Can you go under that nerve? Yeah. Under. Fantastic. Great image. Very good. Okay. Under. Here's that layer. Okay. So we'll get a few mils there, so we'll spread the other side. I think that should be enough. Let's come back to the skin and go to the medial cord now. Just under the skin, almost near the skin, and adjust it and go straight. Yeah. Impression, yeah, that's it. You adjust it. Yeah, that's a good angle you're going, yeah? Because we want to go just under that layer. Just under that layer, and we will start hydrodissecting. So aspirate, 1 mil. If you could go slightly up, yeah, slide along that layer. Okay, hold it. So that looks now to me the one. If you could press a bit harder, okay. Let's go hydrodissect above that round thing, because that's okay. Slide above that. Yeah, good. Go.
Okay, fantastic. You go to the other side. You could see that still that round shape stays.
Yeah.
So that's the nerve. Okay, go ahead. And shall I? If you can scan slightly and get the needle in full view. Yeah, that's a bit more down. Yeah. Can I see the tip of the needle? Scan a bit. Yeah. So also we can wriggle it. In case you can't see, the best thing is to wriggle. Okay, wriggle. And you could see that nerve, the other one, lateral cord, ulnar nerve, is basically getting pushed down. Okay. In this way, you can also leave a few minutes of local anesthetic to cover medial cutaneous nerve. You can see the needle here. Okay, aspirate and inject.
Aspirating.
That's the tip.
Negative.
Yeah.
Injecting.
You could see, yeah.
1 mil.
Let's go a bit more there. And, okay, aspirate and inject.
Aspirating. Injecting now.
Yeah. If we inject into this area, how much we got?
We've got 3 mils.
Yeah, let's inject all of it
Aspirating. Negative. Injecting 3 mils.
in this area. These are the possible variations of anatomy in general population. Is the ultrasound probe, this is what you see in general. You just need to orient it. For pain relief, my patient had only 50 fentanyl on induction, and you can see the monitor how it shows. Look, it's quite stable and the block is very good and it will look after. I don't usually give anything else. Good luck with your block.